Dr. Krishnan, thank you. And I want to thank the organizers for giving me this opportunity to talk about the role of intravascular ultrasound in the management of lower extremity venous disease and PAD. And I have no disclosures relevant to this talk. So I want to start with how I use EVS in the management of venous disease first. So when I see a patient with lower extremity venous disease, in my mind, I'm assessing their symptoms and how they, over the grade of disease they are presenting with. I use CEAP classification. This is the C classification, C1 being the least manifest and C6 being the most severe disease. And I always try to think in terms of pathophysiology. What we know is that venous reflux in superficial veins is the predominant pathophysiology, but recently in last 2 decades, the importance of outflow obstruction is being realized. That's where the role of EVS has recently come into forefront, and that's what I'll be talking about, how to use EVS in this context and what are the guidelines suggest, and what are the areas where we still don't have more data needs to be forthcoming. So iliac vein compression is a disease where multiple imaging modalities can be used. Duplex has a role. I'll mention about that. CT venogram and MR venogram depend on the availability at each institution. Hemodynamics are more into research setting. We don't use it in everyday management of these cases. Venography, in my practice, I use it as rather than as a option to EVS. For me, it is a complementary. For me, it is always a venography with EVS, and I'll talk about it. The reason why I use it as a complementary rather than as a supplementary information in addition to EVS. So on intravascular ultrasound, how does a compression look like? These are some representative images which I took from Dr. Raju's articles. So these images show different grades of stenosis. The top right shows minimal compression, and the bottom right shows the most severe compression with different grades in between. And you have to realize there are 2 types of compression. One is pure compression. The other is a post-thrombotic, where there is presence of septations. And these are representative images of how the septations look like when examined with intravascular ultrasound. This is a classic example of how pre and post stenting intravascular ultrasound will appear. The one on the bottom left shows image pre-stenting with this tight compression, and the one on the bottom right shows post-stenting, where you see a good lumen and the stent is well expanded. Now, Dr. Raju's group compared intravascular ultrasound with the single plane venography, and they showed that venography has poor sensitivity and specificity as compared to intravascular ultrasound. Similar results from when they compared EVS with the multiplanar angiography in a recent video trial, where EVS trumped over multiplanar angiography. There is a recent review which compares EVS with multiple imaging modalities. And when comparing CT venogram with MR venogram, as I said again, it depends on what is available at your institute, but CT venogram tends to trump over MR venogram in terms of anatomical details, and it's a negative and positive predictive value for significant compression. Another utility of utilizing pre-intervention or pre-procedural CT venogram or MR venogram is it provides a definition or more anatomical details about multiple compression syndromes, if there are any anatomical variations to other than the typical compression as represented in these images. And what I've realized is, during my practice, that there are significant variations in iliac vein and how the pattern, how they join with the inferior vena cava. There is one study which of almost 2,500 patients where they had about a 20% significant anatomical variation, which, when you practice this, you have to realize that it helps in determining the stent size, landing of the landing zones for these stents. Now, as the role of duplex, it doesn't, when we manage these patients, if a patient has significant compression and we need to follow this patient for any restenosis, we are not going to perform repeat CT venograms and intravascular ultrasound. So it is important to know how a duplex ultrasound will perform in comparison to IVUS. And there is recent data coming out which shows a good positive correlation, and more studies are needed in how to follow up these patients after stenting and what numbers need to be used on duplex ultrasound. Second thing which I want to focus about IVUS in management of venous disease is that 50% stenosis is, more of a arbitrarily chosen threshold, as Dr. Raju writes in a recent editorial. And what makes the matters more complex is there are guidelines which even use a lower threshold of 30% for iliac vein stenting. More recent data from Dr. Raju's lab again, which mentions that when they looked at significant C3 to C6 disease, there was a range of compression, and they recommend, if in the right clinical context, they recommend proceeding with stenting even if the stenosis is less than 50%. All said and done, you need to realize that iliac vein compression of more than 50% can be an incidental finding in up to 25% cases, as was documented in this study. So what that leads to is that a compression without manifest disease gives us an idea that this may be a permissive pathophysiology and that not every compression needs to be treated. What do guidelines suggest? These are 2011 guidelines in Journal of Vascular Surgery, where they say that it's a class 1 indication to do an IVUS evaluation and proceed with stenting in appropriate clinical settings. More recent appropriate use criteria, where it's they say it is appropriate for to proceed with iliac vein stenting if you have a significant compression in absence of superficial truncal vein reflux. Now, I want you to guys to know that when especially in a patient presenting only with edema, you need to use careful clinical judgment, because edema is multifactorial. And I would strongly recommend in people managing lower extremity venous disease to read this case series of 440 patients published from a group in Columbus, in Ohio, where edema tends to be a combination of both venous plus lymphatic nature. And when you put stents in patients only with edema, you need to realize that you may not get ideal results in these patients. And this is a typical example where a lady has lipedema in addition to fluval lymphedema. And as I mentioned again, the 50% criteria, even though it is arbitrary, but that is what is recommended in this appropriate use criteria. Now, coming to the arterial side, the most important indication in my practice to use IVUS is for vessel sizing. And three indications in my mind when I use IVUS for vessel sizing is when I need to use a covered stent. Number two, when I need to use a supera stent, because there is a definitive correlation. If you undersize or oversize these stents, then you get suboptimal patency outcomes. And then when I have a lesion, is it a TAS C or D lesion where I have no definitive landing zones, I need to define landing zones and vessel sizing. That's where I tend to use IVUS in my practice. Two more indications. One, when you get into sometimes get hazy lesions and you're not sure if there is a significant dissection, IVUS is a good modality. And the IVUS from Volcano gives a chroma flow where it helps in identifying true versus false lumen. Last indication for me and as a re-entry device, which is based on intravascular ultrasound. It's a really nice device when having difficulty for distal vessel re-entry in SFA POP area. That's where I use it in my practice. Two lines about the basic physics of intravascular ultrasound. There are mechanical rotating transducers and electronic phased array. The one which I tend to use is electronic phased array. The reason I tend to use that is it is faster to prep, and it has no limitation on how much length I need to evaluate It comes in 3 different sizes. It's a 5 French to 8.5 French sheath compatible. I use the 8.5 French sheath compatible, or what I call it is a 035 IVUS for venous disease. And I use my 014 IVUS for arterial disease evaluation. Thank you. Any questions?